All right, so let's go ahead and get started. Thanks everybody for joining today. We are here for the Society of Thoracic Surgeons Congenital Heart Surgery Database monthly webinar. Today is Tuesday, March the 19th. So thanks everyone for joining. Hope you guys are having a great week thus far. We have quite a few people from the STS side joining me today. So I'm just going to run down through the list. Let's see, we have myself and Carol Crone. We have Emily Conrad, Paul Meehan. Dr. Meyer is on, Addie, Banu, Dr. Jacobs, our consultant team, Chastity, Leslie, and Melinda, and Sydney Clinton is also joining us today. So thank you everyone for joining on the call. Just have a couple of STS updates to provide today, and then we're going to turn things over to Chastity and Leslie. Not much for the educational side of things today, but we're going to have mainly an open forum type setup for today. But again, we'll go into more detail about that in just a few moments. But regarding the open forum, please make sure you submit your questions via the Q&A. We also have the raise hand function enabled. So if you do have any questions and like to just ask your question, please feel free to raise your hand. We'll unmute you. Just ensure that your microphone is enabled from your end. Alrighty. So with that being said, let's go ahead and jump into our STS updates. The March training manual, as you're aware, is posted. It is available out on the STS website. A brief public reporting update. I'm sure many of you saw the official notification was sent out yesterday to our participants, stating that the public reporting website has been updated with the fall 23 analysis results. If you have any questions about public reporting, please email us at publicreporting@sts.org. If you have any questions, again, just regarding public reporting, please reach out to us directly via our public reporting email address. And I think if we could put that in the chat, that would be helpful. And then those public reporting questions can go directly to Sydney and her team. The Spring 24 harvest obviously is underway. The Spring 24 harvest will include those surgery dates of January 1, 2020 through December 31st of 2023. And I'm sure, as you all are very much aware, the harvest close has been updated to April the 19th. So our new harvest close date, instead of the end of this week, has been rescheduled to or extended until Friday, April the 19th at 11:59 p.m. Eastern Time. And with that, those at-risk emails will be sent to participants 1 week prior to that harvest close date. So just ensure that when submitting those harvest files, please, don't wait till that very last day of the April 19th to get that file in. Please do your best to get that file in at least a day or two prior to that harvest close date, because inevitably something does go wrong. It always happens every harvest. So again, just please work to ensure that you get that final file submitted prior to that very last day of Friday, April the 19th. Again, since the harvest schedule has been updated, I did provide another updated slide. The STS website has been updated accordingly with the new harvest close and opt-out dates for Spring 24. Again, Spring 24 harvest close is 4/19/24, and with the opt-out date of April the 23rd. Fall 24 harvest is scheduled to close September 27th and has an opt-out date of October the 1st. All right, just a few IQVIA updates. In case you are currently running your mortality case eligibility report, there was an additional issue identified. This notification below was posted within the IQVIA platform on March the 18th. So there was a previous release that was deployed on March the 11th, and that that case eligibility report logic was updated only for the inpatient count. And the upcoming update that will be released on the 21st, it will include this update to the mortality eligibility report. So currently, if you're running your mortality eligibility report and you have some inpatients included in those counts, just know IQVIA is updating that report. And as of Thursday, the 21st, those inpatients should fall out of that case eligibility report. If you have questions, if you still have questions after the release on Thursday, please email us at stsdb _helpdesk@sts.org. Again, the case eligibility report is currently still including some inpatients in those counts. The fix is being released on Thursday, the 21st. So as of Thursday morning, the 21st, those inpatients should fall out of that case eligibility report. And again, if you have questions after that fix is released, please email us at the help desk and we can assist with any of those questions. We do have a couple of a few things regarding the primary procedure mismatch report. There are some additional updates that are needed for the version 6.23.2 surgery dates. And just a friendly reminder, when in doubt, for coding, when in doubt, please refer to the training manual as your source of truth for all of your coding guidance. But we do have to, again, make a few additional updates for the primary procedure mismatch report. These updates need to be made specifically, specifically for these 3 codes. So for the first one, for coding for 2330, currently, for the 623 records, it includes the 460 valvuloplasty tricuspid or non-systemic AV valve. So please know that we do need to remove that code 460 from that combination for those 6.23.2 surgery dates. The next code that needs to be updated along the same lines as the 2330 for the 2340, the Fontan plus AV valvuloplasty for that primary procedure mismatch report. For that guidance, we need to remove that, also that 460 from that code as well. And then for combo code 5012, we need to remove also, again, that 460 valvuloplasty code and the 610 conduit placement, the RV to PA, and then we have to add the 830 valvuloplasty mitral or systemic AV valve. So just keep that in mind if you do have questions regarding that, that primary procedure mismatch report. When in doubt, again, please just refer to your training manual. The training manual provides the proper guidance on how to code these procedures for version 6.23 records. So if you have any questions, please feel free to put them into the Q&A. We can address those more specifically here in just a moment. AQO, as you all know, is coming up. AQO this year will be held September 11th through the 13th, with the CHD session being held on Friday, the September the 13th. This year, I can finally announce the location, the hotel location. It will be held at the Lowe's Nashville at Vanderbilt Plaza. So we're looking forward to getting back to in person and having AQO back in person and seeing all your beautiful faces there. We can't wait to get back and see everyone there. New for this year, we have a AQO session proposal form. So this year we'll be accepting proposals for 60-minute sessions to be presented at the conference. The AQO planning program planning committee will review all of these proposals and select those that it deems appropriate for the program. Just to give you an idea of the session proposal form, I wanted to pull it over and give Emily the chance to explain the proposal form just a little bit more in more detail. So Emily, I'm going to pull up the proposal form for you. So.
Hi, everyone. So we have our session proposal form here. I thought I would mention that the deadline for that is on April the 19th. So you have a month to fill it out. On the form, we would like some information about your contact information. And then if you want to scroll down a little bit.
Yes, ma'am.
All right.
I lost my mouse. I'm sorry. There it is.
That's okay. We would like to know the session type. So for what database, and then a title for your talk that you would like to see, the session format, such as do you want to see case scenarios or do you want it to be more staging, or anatomy, more of like a surgeon talk or more of a data manager led talk, or both? Or would you like a panel discussion? You can mark it there. And then kind of if you could provide a description of what you would like to see. And then if you can fill in some learning objectives, it's not required, but it's always helpful to kind of see what you would like to see there. And then also, if you have any speakers that you would like to suggest, we have a spot for that. That's also not required. So if you don't know of a person who would be good to speak on that topic, that's fine. We can also discuss with the planning committee. And then we have a spot for how much time you think that that topic would require. So you can mark that there as well. If you have any questions about this form, feel free to contact me, Emily Conrad. I'll put my email in the chat. And again, the form is due on April 19th, and you can fill out as many as you would like. There's no limit. And also, the committee will review. Not all proposals will be accepted, and they're also up to the discretion of the committee. Like, say, we really like a topic, but we have a different speaker maybe that we had in mind for that. We might change things up, but it's great to hear from everyone, your ideas, so that we can plan a conference that is exactly what you guys would like to see. And then I wanted to mention about registration. We're hoping to open that in the beginning of April. So we will be posting that on our website here shortly. And we'll also post a link for that for the Lowe's. We'll post that shortly too. We don't have the block information online just yet, but we will very soon.
Awesome. Thanks, Emily. And Jocelyn had a quick question. She wanted to know if we were going to have a virtual option as well.
Yes, we plan to have a virtual pass option for this meeting. We will be recording the sessions in Nashville, and then we will post them at a later date, probably like a week to 2 weeks after the conference. So the virtual pass attendees will have access to like on-demand content, e-posters, and things like that ahead of the conference at the same time as our in-person attendees. But then you'll just get information about those recorded sessions in Nashville a little later. And then we will also have a webinar after the conference. We'll bring back some of our speakers so that the virtual attendees and our in-person attendees can get any additional questions answered that you weren't able to at the time of the conference.
Awesome. Thanks, Emily. Perfect. All right. Next, Chastity just has a quick clarification, and then we'll start tackling any questions that you guys have prior to harvest close. Chas?
Absolutely. Thank you, Leanne. Uh-oh, I lost my screen. I'm coming back. Sorry, we're all having technical difficulties today. So if you'll go to the next slide, Leanne, as you recall, last month, Leslie and I presented a couple of updates that were made to the training manual. And one of the updates was related to the post-operative event of acute renal failure. And so as you recall, we included some new diagnostic criteria for patients that are younger than 18 years of age. And the question came up, and I apologize that I'm not sure which of you asked the question, but the question was, are we able to go back, from July through March and update cases based on the new clarification to the definition? And the answer to that is no. And this is to be consistent with all CHSD and actually all STS database definition updates, that when we make an update, we do not expect or want data managers to work backwards and go back to previous cases. So do not go back and recode your data prior to the updated definition. And the updated definition for the post-operative event of acute renal failure was effective March 1st of 2024, as you will see outlined in the training manual. So thank you for your question. And I just wanted to bring it back to make sure everybody understood. And now we want to open it up. Leslie, Leanne, and everyone on the panel for an open forum for any harvest related questions. Again, we want to keep this away from clinical coding questions specific to your patient data. Those belong in the FAQ box that the core group reviews. But if you have questions related to harvest, we would like to open it up to you now.
Perfect. Yeah, and if you also have any other questions, general questions related to the database, public reporting, just anything, just, for free, this is a great opportunity to ask those questions too. We'll answer any questions that we possibly can. If we don't know the answer, then we can certainly, get you to the right people to get those addressed. All right, we do have a couple of questions. All right, our first question from Jen regarding the primary procedure mismatch report. Will these be updated prior to harvest close?
Yeah, thanks, Leanne, for that one, Jen.
Sure.
Right now, we don't have a time frame for when those will be updated, to my knowledge. That is why we're suggesting that you use the training manual. And also just wanted to put a little plug out there to the data managers who let us know about that issue. We weren't aware, and of course, even when we test these, we don't have every single possible combination of procedure codes in our data. So a huge thank you to those data managers who brought that forward. And then of course, we'll update everyone as soon as we do know a timeline. Perfect.
Yeah, thank you so much, Leslie, and thank you, Jen. Yeah, thanks to those data managers for letting us know. Like Leslie said, we unfortunately can't address every single one. So we are, in testing. So we appreciate that. And we are working with IQVIA to get those updated as quickly as possible. And unfortunately, I don't have a timeline just yet. I have a meeting with them on Thursday. So hopefully I'll have more information as soon as possible. And I'll share that with you guys as soon as I can. Our next question from Nancy. Do you prefer we keep inpatients in the database for submission or only put in completed patients? Does this hurt us if we don't include them? Thank you. Last week it showed my missingness. Is this fixed now?
Yeah, I could take this one too, Nancy. Thank you for your question. So the missingness report is working okay. Like the number it's going to show you includes inpatients. So if anything, your number of ineligible might look higher than it really truly is. So if you're still under 2%, you're just fine. That's what will be updated in the next couple of days to exclude those inpatients so that it will be a more accurate number to use in your kind of cleanup process. The process though for submitting patients who are still in-house, those should all be submitted with harvest, even if they're still in-house, if they're in another hospital and haven't been discharged, they still need to be submitted. There are ways and different logic that's applied at analysis to make sure that we're not including anyone who hasn't been discharged in our mortality reports or in our numbers, but it is imperative that you submit them in a timely fashion because, of course, as you probably know, with audits, we also check case logs, and those patients would be on your case log, and you wouldn't want to risk not matching your volume in that case. So yes, submit them as you go, even if they're inpatient. Utilize those new fields in 623 to say that they're either still in your hospital or in another hospital. And then the harvest reports, which will be updated shortly to kind of exclude those from the numbers. Hopefully that made sense and wasn't too wordy.
No, it was great. Thank you, Leslie.
Actually, Leanne, can I pipe in? I think even to go take it a step further, I think when they're calculating the percent missing for which records are going to be excluded, they look at the field that says, is this patient still in the hospital? And if they are, that record's not included in the calculation. So yes, to submit it and just make sure that that question is answered correctly, that they are still in the hospital, and then everything else should be fine.
Let's see, Jennifer, can you show us again how the steps to the training manual? You're a new user would like to learn. So you need assistance getting to the training manual. I'm assuming that's steps to the training manual. Yes. So from the STS homepage, you can get there a couple of different ways. The quickest way I like to get there is just to go down here and click on the data manager link. From the data manager link, you can either click on resources for data managers or data collection forms. Either one will get you there. The quickest, most direct route is data collection forms. Once you come to the data collection forms page, just click on congenital heart surgery so you don't have to scroll. And here you have each data version listed. We're currently operating under data version 6.23.2. And the training manual is, the link is here. You can right click on it, open that link into a new tab. And here is the training manual. Regarding the training manual, important information, this document is extremely long. I have added some bookmarks here, so you can make use of the bookmarks so you don't have to continue to just scroll through the various sections. Just use those bookmarks. You'll notice that some of these have additional drop downs here. Whenever I make updates, I will bookmark the updates for that specific month. For example, for March, we updated some information for these following harvest codes for harvest code 880, and it'll take you straight to that particular update where you can see where it was updated for that particular month. So you don't have to sit there and scroll for each one. Just a little tip. Okie dokie. Hopefully that was helpful. If you still have questions or issues afterwards, just please feel free to email me directly and I can assist you. Next question, if we are unable to meet the due date of April, will we be able to submit all data, including the one that is due for April during the next submission due date? Yes. So you can submit, if you are unable to participate in this April spring 24 harvest, you can include that data in the fall 24 harvest submission. So you can resubmit data for the entire 4-year reporting period. If you've gone back and cleaned up additional, data that was previously submitted, absolutely resubmit that data in the next harvest.
However, just to add to that, in the next harvest, we would lose 6 months of data and add 6 months of data. Yeah. So it won't be the same 4-year reporting window. And so just so you know, some of your cases would then not be included in that next harvest report that should have included in this harvest report, if that makes sense.
And Carmen, I showed Chastity's slide, and looks like Amy has a question. Regarding the acute renal failure definition change, I spoke with one of our surgeons, with one of our cardiac intensivists that advises on the database, and she said they would likely never document anyone having acute renal failure unless they need a dialysis treatment. If the patient just has elevated creatinine lab values, they document this as acute kidney injury, not acute renal failure.
Thank you for that feedback, Amy. I think that that's the point. We don't want to pick up acute kidney injury, and that's why we made the change to the definition. And so if your intensivists are not calling something acute renal failure, or your nephrologists are not calling something acute renal failure, then that is the point. We really want it to be that we're picking up acute renal failure as a post-operative event. Leslie, do you have more to add there?
Nope, that's what I was going to say.
All right. Thank you. All right. Let's see, Beth. Could there be an enhancement made to the IQVIA reports for cleaning data if the inpatients are coded as such that they do not show up on the reports, especially the MVR? I know the missing variable report, that one operates, there's no criteria, there's no rules or anything applied to the missing variable reports the same way as the old historic data quality reports. The missing variable report just reports any variable that has missing data. We don't know if it's missing for a reason or if it's missing because it's actually missing. You just simply forgot to enter that data. We can possibly, I think maybe I don't know if we have a filter on there, maybe we could look at adding an inpatient filter. I don't know, but again, there's really no additional rules or anything instituted for the missing variable report, but we can definitely take that back and discuss it with IQVIA and talk through that. So thank you for that feedback. That is, let's see. Let's see here. Agree with comments about acute renal failure. Physicians don't often document this, but labs meet definition, and acute kidney injury documented.
And again, we don't want
Yeah.
to pick up acute kidney injury. We're truly looking for acute renal failure.
Yep. Length of stay is a big initiative. Will you consider adding more drill down graphs? We can definitely take that feedback back. If you haven't, Nancy, if you haven't submitted that to the help desk, that would be great. We could add that to our list of enhancements. So if you could submit that to STS,
Leanne, it's
Yes.
Carol.
Yes.
Can you hear? Quick question.
Yes.
On the length of stay, is this something that will be coming out on the executive summary?
Yes. I think, yes, I believe we did add length of stay to the executive summary. So yeah, that's a good point, Carol. Thank you for that. We did add length of stay for the executive summary that'll be coming out, I believe next quarter. I believe, but I haven't provided a lot of information.
But I don't know that it has any more granularity than what's already reported with length of stay, because we have length of stay by benchmark operation and then length of stay by stat mortality category. But I don't know if, Nancy, you're looking for something more granular than what's already provided.
If you could provide maybe an example of what more granular, like what more you're looking for, then we could probably, then we could talk about that and see what more information we could provide. Thank you, Nancy. Let's see here. Don't know if we can get this granular, but for those that use cardio access when we submit, are we not supposed to check exclude patients still impatient to process the file that gets uploaded to IQVIA? Just clarifying.
So this
I,
is the reason you're confused by this question, Leanne, is because this is something that is native to cardio access and not in the specs or anything to do with STS or IQVIA. So if you're using an enhancement or something from a vendor, I can't tell you how to use that or not use that. But as Leslie stated, all cases, whether inpatient or not inpatient, should be uploaded and sent over to IQVIA.
Thank you. Yeah, I've never seen the software, so STS hasn't seen the vendor software, so I'm sorry, I wasn't familiar with that. Working backwards to reach 2021, where can I find each case? Where can I find which cases per year period are matched for each version?
I think that's just the 341 verse 623. So for simple terms, all of your cases through June 30th, 2023 will be in data version 3.41. And everything from July 1st, 2023 forward will be version 6.23.
Thank you. Let's see. So just to be clear, getting back to the renal failure, if lab values are met, there needs to be clinical documentation of acute renal failure.
I guess I would go the opposite of that, I have the definition of acute renal failure. And then do I meet the other parameters? But if you have specific examples that you're struggling with, Amy and then Marina, why don't you send those in as FAQs? Because I don't think that we can blanket answer all of your questions. But if you send in your specific case that you're struggling with, we'll be able to give you an answer. But we want to discriminate against picking up acute kidney injury. We're really looking for acute renal failure.
Right. Marina says she doesn't have a specific case.
Also to Marina, this we presented this one on the last call as well. If you want to review that one, I think we went into a little bit more detail. Mainly today, we wanted to update on the timeline that you don't have to go back and recode.
Perfect. Let's see here. All right. Any other Oh, Nancy, I don't know if, Nancy, your hand was raised. I don't know if you had a question. I think we answered a couple of questions. I don't know if your hand was still raised back. Just there. And Banu, thank you for putting the help desk email in the chat. So yes, for all data submission questions, please reach out to the STSDB_helpdesk at sts.org if you have questions related to your harvest submissions. Marina, I think the problem is semantics. What are you defining as acute renal failure? What you are defining as acute renal failure is being called acute kidney injury by practitioners.
Yeah, thank you, Marina, for that feedback. That we know that, but the point was that we wanted to make sure that if we're only quote unquote picking up acute renal failure as a post-op event because of the labs or low urine output, that some clinician has called it failure in the chart, that we're not picking up acute kidney injury.
Right.
And obviously, if you're getting dialysis for renal failure, then you automatically meet the treatment, then you automatically meet the definition. I agree. When you come across some cases in your facility, perhaps this will make more sense. We don't want, by the nature of our original definition, we were picking up acute renal failure and kidney injury, and we wanted to be able to discriminate between the two.
Yeah. Perfect. Thank you, Chassie, Liz, and thank you, Marina, for your questions. We know you're not trying to be difficult. We're just trying to make sure everyone understands the parameter. So yeah, we understand. Let's see here. Let's see. All right, Amy. Don't have specific cases. We have some reports created as we track acute kidney injury for QI purposes. Just want to make sure we are not to capture acute renal failure in the STS database for those that meet on lab value UOP. Our clinicians will not document acute renal failure. They will say AKI. All right. All right. Any additional questions from anyone regarding the harvest coming up? Again, the harvest close date was extended to April 19th. And if you have any questions regarding data submissions, you can ask them here, or you can reach out to STSDB_helpdesk at sts.org. And if you have AQO related questions, you can feel free to reach out to Emily directly, econrad@sts.org. So yes, Amy, can you flash back to the primary procedure mismatch slide, please? Yes, ma'am. So again, there are 3 additional updates that need to be made to the primary procedure mismatch report. Again, I don't have an update on when these will be, when this will be rolled out. I don't know if it'll happen prior to the harvest close date. So just take note when you're coding 2330, 2340, and 5012 that these updates do need to be made to the primary procedure mismatch report for these procedures. So just again, whenever in doubt, if you have questions when coding those procedures, please refer back to the training manual as your source of truth for coding for these specific procedures. You're welcome, Amy. Happy to help. Let's see here. Next question. Is there a list anywhere of data fields that absolutely cannot be missing for submission? So yeah, go ahead. This is a question we get a lot. Go ahead.
There's not a separate list posted. So if you review the report overview, it will talk about missing data and how either individual cases or an entire program can be excluded from the report based on the thresholds of missing, as well as the IQVIA tools if you go into the MVR, the missing variable report, it will show you all of your missing fields, and then you can filter by those from the anesthesia report, those in the mortality analysis, and those in the risk model, I believe. And so those broken down, the risk model fields as well as the mortality analysis are absolutes. And then the mortality eligibility report as well. And so those are all of the things that help you determine what is absolutely required for data submission. It's important to note, though, that all of the fields are treated equally, and you want as complete of a data set as absolutely possible. Understanding that some things are missing, just not documented, or you can't find it. But go ahead, Leanne, and go through this.
Yeah. Again, in terms of data cleanup, this is a question I get a lot. You know, there's a lot of information reported in the missing variable report and things like that. And obviously you want to try and focus your data cleanup, make it as efficient as possible. You know, set your priorities. I always recommend, you know, the very first thing, you know, use your analysis overview like Chastity had mentioned, specifically determination of case eligibility for inclusion in the mortality analysis. We do have those thresholds. We have the 2% missingness threshold. Information on the determination of case eligibility for inclusion in mortality analysis can be found here. Obviously, you need to focus on your database discharge status, status at hospital discharge, status at 30 days. Please know for these 30-day status, a value of unknown is considered as missing data. Also, there are the risk model specifications are here. Obviously, you would want to focus your data cleanup on risk model variables that are included in the risk model. Those variables are included here. So again, a lot of information can be found in this analysis overview. I encourage you to download it, keep it by your side. If you have not looked at it, a lot of information here, and you can use this to help prioritize your data cleanup. Again, focus on those risk model variables, focus on the mortality variables, and then put your main efforts there, and then continue on throughout your missing variable report for other additional variables that have missing information. All right. Any other questions regarding harvest, AQO, database participation, anything of such?
I wanted to
Emily?
say about AQO, someone, I think Beth just sent me an email about it, so I thought I'd also tell everyone here. She asked, is congenital just one day at the in-person meeting, or is it over all of the days of the conference? And so I thought I would let you know each on September the 13th, which is the Friday, will be the congenital day. So it'll be a full day of congenital content on Friday.
Awesome. Thank you, Emily. And yeah, and please, you know, encourage you guys to fill out that session proposal form. So we have all, you know, make sure that you all have the AQO that you want and need. We want to make sure we're giving you the content that you all need for sure. Okie dokie. Let's see here. Any other additional questions? We got about 20 minutes left, but Emily is putting in the chat the schedule for AQO. September the 11th is going to be the GTSD Intermax and PDMax session. So there'll be concomitant sessions going on that day. And then September the 12th will be ACSD, and then 13th will be CHSD. All right. Any additional questions? Again, just a reminder for anyone that joined late, the harvest again was extended to April. The harvest close was extended to April the 19th. The at-risk for exclusion emails will go out 1 week prior to that harvest close date. Those emails will only be sent to those sites who are at risk. Please, you know, make every effort to clean up that data. If you have any questions once you receive that at-risk email, please email me directly. what else? Trying to think of anything else you all would need before harvest close. I can't think of any additional information. Chassless, anything, words of wisdom, other than please don't wait till the very last day to submit that file.
Absolutely. Start working early and ahead, because in case there are any vendor issues that you need to work out prior to submission, you want to get started now.
And inevitably, there's always something. So,
Yeah, and so if you're waiting on an FAQ, we have another call tonight to go through the last, I think we have 12 or 15. So I'm going to get those responses out this week, and then I'm out for a week. So if there's a delay, that is probably why.
awesome. Thank you. All right. I'm not seeing any additional questions come in, so I'll give you about 15 minutes back of your day. Thank you everyone for hopping on the call today. Let's see. Yeah, the FAQs, the core group does an amazing job. So thank you all. Thanks for joining today. Again, if you have any questions that if you think of after the call, please just email me directly. Happy to help in any way. And with that, I guess we'll call it an afternoon. And I hope you guys have a great rest of your day. Thanks again for hopping on. Thanks everyone from the STS side, core group side, and Sergeant Leadership. Thank you guys for hopping on today. I appreciate your assistance.